One of the first lessons that I was taught as a new medical student by our hospital's most esteemed diagnostician was that you shouldn't believe anything that you read in the patient's chart because it is full of lies. And generally, I've actually found this assessment to be quite true, both on paper and electronic medical records. And those times in medicine where you get burned, they often rely on a piece of information that you read in a patient's chart that in fact turned out to not be correct. And in theory, with electronic medical records, we have the potential to remedy this problem and to actually verify what is true and what is false in the medical record and to display the level of evidence or quality or truth beside every piece of data inside of that medical record. And so I have a two-part post. The first part is looking at how we determine if data in a medical record is true, how fake data enters into the medical record, and in practice how clinicians verify what is actually true. And then the second part goes to propose some ways which we can help verify medical diagnosis, and this really focuses mostly on the past medical history, but you can consider applying these concepts to other parts of the medical record. And the proposal or the solution part, the second half of this post, will really focus on very high level and some abstract concepts. But I do think that they could be useful. And I know that people have been working on this problem. And so hopefully some people either write to me at gschmidt@medmb.ca or through Twitter contact me, because I would like to see some of the best and most cutting-edge solutions out there for ascribing levels of truth to data in medical records. Because as I say, I know people are working on this. So let's start with the first part, where we determine if something is true. And this part of the article, reflects the fact that I did study theology and philosophy in undergrad. And so when trying to understand if a fact in a medical chart is true, there are two questions you may want to ask. The first is, what is the evidence that supports or refutes the fact? And then the second question is, what is the strength of that evidence? Another way you could think about it in philosophy, we would say, is premise 1 plus premise 2 plus premise 3, do they all then lead to support the conclusion? If we wanted to make the allegory, we'd say, what are the premises that support the conclusion? That's the same way as thinking of what is the evidence that we need to support the fact. And then the second question is, what is the strength of each of those premises, or what is the strength of each of those facts? And so when we think about something like a medical record, let's go through two very straightforward examples. And I've deliberately chosen these examples because the diagnosis in these two cases, the first HIV and the second diabetes, are reasonably straightforward diagnoses, meaning that the diagnostic criteria rely on reasonably objective blood work. We don't need clinical opinion or expertise. And so in theory, it should be a reasonably straightforward way to determine what is true and not. So let's delve in. The first example. The past medical history states the patient is HIV positive. Then the question is, what is the evidence for this fact? Is the fact in the past medical history saying HIV positive linked to a point of care rapid HIV test? These tests may have false positive rates, which are frequent depending on the model you use. So the truth that the patient actually is HIV positive is actually not particularly high based off of a walk-in point-of-care test. However, if that issue or if that claim statement was linked to a high HIV viral load titer, well, that would actually support the claim with quite a high level of evidence. But because that one viral titer might have been a clerical error, having multiple high viral load titers actually are a much higher level of evidence than just having the single titer. And in some ways, just to add to the complexity of this, to link a negative HIV viral load titer as refuting evidence against the claim that a patient is HIV positive actually doesn't work, because the viral load result might become undetectable if therapy is effective. And so as you can see, even something as reasonably straightforward as if a patient is HIV positive can become a little bit complicated. So if we linked, let's say, the support that the patient is HIV positive to a piece of data such as the fact that they're on antiviral medications, we have to keep in mind that this is a secondary or a surrogate marker which is inferring the diagnosis, right? It's not actually linking that data to a primary diagnostic marker of the condition. And as we'll see a bit later in the next example, why this can be a problem. So that's all been studying the first part of that our argument, which we were laying at the start, which is what is the evidence which is supporting the fact. Now let's go in and actually look at the strength of those pieces of evidence proposed. For instance, was the lab test from a patient's recall? Was it manually entered into the medical record? Was it entered into the medical record, that lab test, the day of the test or 6 months later? If it was entered manually, was it later confirmed by another clinician? Or was this test auto-captured from a fax which then went through optical character recognition and was translated into a piece of digital data? Or did the test come directly from the analyzer? All of these different modalities affect and impact the strength of that piece of evidence in trying to then eventually support the conclusion. And so precisely how the evidence supports a conclusion and precisely the strength of the evidence, all of this together will need to be evaluated. And exactly how these interplay is a matter of debate for another time. But I just wanted to demonstrate that it gets tricky. Let's look at one other straightforward example. Actually, sorry, just before we do that, I want to emphasize a very important point. And I want to show that the easiest way to simplify the complexity of trying to come up with different levels of supporting data, the easiest way to simplify this problem, which we just looked at, is to actually be much more specific and prescriptive in the description of the diagnosis going into the past medical history. For instance, instead of saying that the patient is HIV positive, which, as we said, can have many different layers of evidence, each with different levels of quality and accuracy, what if we just said in the past medical history that there was a positive, rapid HIV test November 4th, 2017? Well, to prove that statement is actually very straightforward. We just need to link it to the positive HIV test, right? If the other statement was that there was a positive Western blot or a positive P24 antigen, again, these are all statements which are very easy to prove and to validate with a high level of certainty. Again, to say that the patient was HIV positive with an elevated viral load, this is a specific statement which we can validate. As we get into more complex statements, so that the patient is HIV positive, this would be a statement which, as we looked at in the previous paragraphs, actually requires a lot more consideration on what it means for that simple statement to be true. Whereas if we have a more longer statement with more description and detail, it's actually easier to support the truth of the more detailed item in the past medical history. Let's look at one other example. For instance, a patient with diabetes type 2. So the first part of the question, again, the patient's chart states they have diabetes. Well, what is the evidence? How can we ascribe what level of certainty can be given to this claim? Is the claim that the patient has diabetes a result of the fact that their hemoglobin A1C result is 10%, which is grossly elevated and therefore strongly supports the diagnosis? Or did the clinician write that the patient has type 2 diabetes on the problem list because the clinician saw that the patient takes metformin? Again, this is an example of that secondary data, which is not actually primary diagnostics data. Now, we now move into the second part. Let's analyze the quality of the data. Was the A1C of 10% similar to the previous example? Did it come directly from the lab analyzer? Was it entered by hand? Was it scanned in? Was it recalled by the patient? These all affect the quality of that data, which all affect the certainty of the diagnosis. Similarly, was the medication metformin simply on a list that the patient's spouse pulled out of their wallet, which was dated from 7 years ago, which often happens, or was that medication actually imported directly from their primary care physician's medical record? Or was that medication confirmed with a list from the pharmacy's medical system of the medications dispensed? Or was it reconciled against the pill bottles brought in by the patient? Again, these are very different ways to get the data into the system that the patient is on metformin, and each has different levels of confidence that the patient actually is on that medication currently. And now, even in a straightforward case like this, there's still a lot of uncertainty. For instance, that A1C result, how recent is it? Was it a single measurement? Was it a repeat test? Was it falsely elevated because of drug interactions or certain anemias or genetic conditions of the patient? Similarly, even if the strength of evidence for a patient being on metformin might be high, we can't directly deduce that the patient has diabetes. For instance, what if the metformin was being used for something other than diabetes, such as to assist with contraception or polycystic ovarian syndrome? And this shows again that really when we're trying to understand the certainty of an item in the past medical history list, we need to have both strong evidence, and then we have to attach that evidence in a very deliberate way with strong premises to the issue. Or as we would say, we need to have strong premises, and they must be linked properly into the conclusion. Now, just a quick aside, it's important to remember that when we're displaying something in the medical record, something can be internally true. For instance, the patient might be on metformin, and we may have a high level of certainty about this. But there's actually a separate task which we need to do, which is to link an internal truth about the medical record to the actual truth of reality, which is the patient has diabetes. And as we can see, trying to do this is a little bit tricky. And I know there's a lot of efforts out there to use machine learning to analyze patient charts, to look through their medication lists, to look at their labs, to look at the physician notes, to try to deduce what diagnoses and issues should be inside of a patient's past medical history. But the thing I think which is important to realize is what exactly is the gold standard that we're comparing this against? Are we simply comparing the medical record against the medical record? Because itself that it might be true, but if the medical record actually doesn't mirror reality, we don't have a very good gold standard comparison. All right, we're going to move now to the second part of this presentation. Now that we've mused about different ways that evidence can be true, we're going to move into more of the practical part of how does fake data enter into the medical history. And the reality is that this is pretty easy. And this happens both on paper charts and on digital charts. The sequence, quite commonly is that a patient comes in, they're seen, let's say, by a medical student. That person writes on their past medical history that the patient has chronic obstructive lung disease, COPD, and that's pretty much it. Another clinician will come along, they'll be performing another consult, they'll refer back to the initial consult, which was filled out the first time, see the word COPD, copy that into their own list of what the patient's past medical history is, and this continues time after time for a year and decade. And then perhaps several years later, or maybe a few decades later, the patient may represent, this time with a respiratory condition, and in this case, perhaps someone digs deeper into that past medical history to try to really understand the supporting evidence for the claim of COPD, and they may discover that in fact the patient never had it, only the chart did. And so this is very common. We see this all the time. And the same could happen if someone writes that the patient has a history of depression or that they had hypertension or a stroke in 2003. Once something's been added to a patient's past medical history, quite common, it's difficult for that to actually be removed from the list. The other consideration, of course, is that even if someone were to remove that item from their own personal list that they've written out for the patient's past medical history, another clinician may come along, look at the patient at that list that the clinician who removed it has, think that that list is incomplete, and then on their own list go back to re-add the item which had been previously removed. And so you can see it's very easy for fake data to continue to perpetuate in medical charts. And for those who maybe are not as familiar with the medical chart, there are a lot of other sections within it, and each of these sections can contain fake data, and the means of generating this fake data is slightly different, but the concepts are generally similar. These other parts of the medical chart are, you have, as we've been discussing, the past medical history, the past surgical history. You'll then have allergies, medications, consultant notes, patient histories and symptoms, family medical history, a patient's social history, which are their risk factors and exposures and lifestyle and economic factors. You'll have a section of results and imaging, labs, diagnostic tests and investigations, and ultimately clinical impressions, diagnosis, and plan. All right, let's move into the third and final section of this post, which is how do we determine the truth in medical records today? We've been discussing a very complicated, elaborate process of trying to understand whether something's actually true. And this seems like it takes a while, is a bit tricky. How do clinicians do this in practice on a daily basis? Well, there are generally two approaches from what I've seen. The first is what I would call a manual fact check. And in this case, the new clinician coming into the chart will manually fact check the details in that chart themselves. Now, the level of depth that they go into on this fact check is contingent upon many factors. It's based on how much time they have, how critical the piece of information is to their work, if that clinician must track back each document to their original source. And trying to get to source documents might mean re-asking the patient specific questions, finding original copies of labs and tests, or contacting their previous medical offices and hospitals to fax over old consultant letters and documentation. And so this process of manual fact-checking is very time-consuming. Some clinicians may fact-check the majority of the chart and find probably quite a lot of mistakes. Other clinicians rarely fact-check the written record, and they likely don't even realize they've screwed up when treating the patient. And so the problem is that the criteria that each physician uses when reviewing the data is both unique to the individual, their training and their knowledge and expertise, as well as how busy they are, how interested they are in the case, how important that patient is to them, and how crucial trying to get to the bottom of the issue is. And although there are diagnostic guidelines and criteria, it seems more often precisely what criteria the physician is using to establish a diagnosis and the veracity of data in a chart is really based upon the time, the patient, and the physician which are being brought together to study that chart at that time. And so it's very variable. And as I've been trying to show, it's prone to variation will ultimately lead to wide variation in quality of care and then wide variation in outcomes. As I mentioned, though, not all physicians fact check the entire chart. In fact, most physicians rely on workarounds. And the workaround is, based on my observations, that people will look to see which notes have been written by other clinicians. For instance, if a note was written by a third-year medical student, you may take most of it with a certain amount of skepticism, knowing that often medical students miss the mark in accuracy. It generally might be correct, but there's a few key parts which are just not accurate and not true. So therefore, what often will happen is that certain clinicians within a hospital will become universally recognized within that institution as writing comprehensive, accurate notes. And so if a patient were to present to the emergency room, the physician on call may go to see the patient and then open up their record at the same time, find a note which was written by one of these other, one of the brilliant clinicians, and essentially copy the past medical history from the other clinician and assume that because that physician's name and signature is on the document, that therefore the past medical history as described is complete and accurate, and therefore essentially copy it over without having to repeat the manual fact-checking process. Now, is this clinical freeloading? Is it medical plagiarism? Or is this just the standard of care? I'll leave that for you to decide. But the reality is, this is how the practice of healthcare operates. And as you can likely and have already started to compile, there are many reasons why this shortcut for data verification is very prone to error and can perpetuate and copy forward incorrect data for decades to come. Which gets us back to the start of this presentation, which was, do not believe anything you read in the patient's chart. It is full of lies. We'll now move on to the second part, which is, how can we help confirm if items in a patient's past medical history are actually true? And how can we automate this process?